much. I'm Scott. I'm from Cyberonics. I've been asked to introduce the next speaker, which is Dr. Sumeet Vadera from from UCI, University of California at Irvine. Very lucky to have Dr. Vadera here. He is now the director of epilepsy surgery at UCI and is a neurosurgeon that was trained at the Cleveland Clinic. And he's now been at UCI for about a year or so. He does both pediatric and mostly adult neurosurgery. And he has been very, very busy doing all different kinds of epilepsy surgeries at UCI. And I think he'll be talking to you today about a lot of the different surgical options that are there for patients who have refractory seizures. So please, let's give a warm welcome to Dr. Vadera.
So thanks a lot, Scott. Thanks. So as Scott mentioned, my name is Sumeet Vadera. I do epilepsy surgery is my specialty in neurosurgery. I also do general neurosurgery, spine, and brain tumors and things. But really, epilepsy is my passion in terms of the surgical things, the neurosurgical options, because epilepsy is one of the few things that we can actually treat. You know, back pain, it's a difficult one. People who have brain tumors, that's another difficult one. But people who have epilepsy, those are some of the patients that we really can make a big difference in when we talk about epilepsy surgery. And unfortunately, people really don't understand epilepsy surgery, or they don't know about epilepsy surgery. And I'm amazed every time that I'll talk to patients and I'll say, you know, this is an option. And they'll say, I didn't even know there was an option of surgery for, you know, what I have. What we wanted to do here today was talk about some of the options in epilepsy surgery, because I think that, you know, just hearing about it and putting it in your minds and you can think about it and, you know, go through the process. I think that's really an important thing for people. The way I want to kind of go over it is that, well, first of all, I want to say that if you've failed 2 to 3 medications in epilepsy, and you know, you continue to try more medicines, and that's really what a lot of the community neurologists will try, is they'll keep trying more and more medicines. But if you look at the literature says after about 2 or 3 medicines, the odds of becoming seizure-free with medicine alone is almost 0%. So what that means is that after you've failed 2 or 3 medicines, then you need to start thinking about the next step, which is to be discussed or evaluated for epilepsy surgery. Now, what does that mean? Well, first of all, the centers that, you know, the community neurologists generally are not the people who would do this evaluation. What you really want to do is go to a level 4 epilepsy surgery or epilepsy center. And what that means is that center is able to look at you coming in, and they can look at all your EEG, your MRI, all the, you know, information we have, and we can offer you the best option, whether that's continued medication or surgery or a combination of both of those. In terms of the surgeries that we have, the first thing I want to do is kind of break it up in your mind that there are many different surgeries that are available for epilepsy surgery, and part of what makes it interesting very interesting to me is that you have to tailor the epilepsy surgery to the patient. It's not like a one-size-fits-all thing. And so I think that's partly also why people don't know much about it, because we have so many different options and so many different things, and not every option is right for every person. But with that being said, the first thing you want to do in your mind is think about the type of epilepsy you have. And this is what they would do at a level 4 center. You want to look at and see if you have generalized epilepsy or if you have a focal epilepsy. That's the first and foremost thing. If you see that it's generalized, then the options are less, but there are still options available. For instance, if you have drop attacks, you know, we have a very good surgery for that. It's called a corpus callosotomy. If you have generalized seizures, but there's no good option as to how to, you know, as to where it's coming from or other surgical options available, we have VNS, which is a very good option for people who have generalized seizures. And I'm going to talk about all that stuff in a little bit, but I'm going to go down this other path, which is the focal epilepsy, because those patients also have very good outcomes, and I think some of those people are the ones that really, you know, are not evaluated for epilepsy early enough, and those are the ones who really we can, you know, catch those patients. So focal epilepsy, as Dr. Lerner had said, was you have one area in the brain that starts the seizure and it quickly goes to the rest of the brain, and that's really that's focal epilepsy. Now, the beauty of focal epilepsy, one of the good things about focal epilepsy, is that wherever that area is, we can treat that with a surgery. Now, where do we go from here? So we said we have focal epilepsy. Now, how are we going to treat that? Well, the first thing is we have to figure out where it's coming from. So the way we do that is we do MRI studies. We look for a lesion. Generally, lesions kind of point towards where the area of the seizures are coming from. We'll possibly do a PET scan, a SPECT study, WADA test, all these different tests. And at the end, what we do at these level 4 centers is we look at all the different testing that you had done, and we say, do all the tests point to one area in the brain that we think the seizures are coming from? So, for instance, one of the most common types of epilepsy in people who have surgical epilepsy is temporal lobe epilepsy, especially mesial temporal sclerosis. So, if you think about the temporal lobe as your fist, the mesial temporal lobe is your thumb, the deepest part of your temporal lobe. That's where the hippocampus and the amygdala are. And it's pretty common, especially people who are in adults, and to have seizures coming from that area. And when they do, the temporal lobectomy is an extremely good surgical option with the seizure-free rates between 60 and 80%. So in those patients, that's really I've talked to many of my patients who I've done surgery on, and when I talk to them, they say, until now I didn't know that there was a surgical option to cure my epilepsy. And I will tell you that I've done these surgeries on many patients just since I've been here, and they come back and they're very happy with the results, and they're seizure free, and it is a very, very good option for patients when we can localize the epilepsy based on just imaging and non-invasive studies. Now, that's one arm of one option that you can have. A different option is that we do the MRI, we do the SPECT study, we do all the other testing, and at the end of it we say, well, the MRI shows us this, but the PET study shows us something different, and all the studies don't correlate with one another. And so when we have that, then the next step we have to do is what we call invasive monitoring. And what that means is that we implant electrodes either on the brain or into the brain, with the idea that we're looking to see where the seizures are coming from. And the way that we implant those, or the way we decide how we're going to implant those, is that we have a discussion amongst the neurosurgeons, the neurologists, the radiologists, basically everyone who's involved in your care, and we say, these are the areas we think the seizures are coming from, so we're going to cover those areas with these electrodes. When we do that surgery, there's various options for that surgery, and we don't have to get into the specifics of it, but after we implant the electrodes, we admit you to the hospital, you stay in our epilepsy monitoring unit while we look for where the seizures are coming from. And then when we find that, then we bring you back to the operating room, we take out the electrodes, and we take out the area where the seizures are coming from. And so those are kind of the broad overview of the types of seizures that we offer surgery for, and what the options are available. It's kind of hard to do this discussion without a PowerPoint, because it's hard for me to talk about these surgeries and you don't see the incisions or what the surgeries entail or anything. But if you have questions, I think this is probably a good thing. We can kind of just open it up to questions. Go ahead. Okay.
So the hepatologist didn't talk about when they put the electrodes inside. I decided to go against that right now, but are they able to walk around and move? Because when she's just sitting, because they think it's an energy supply thing that's causing the epilepsy, she doesn't. There's the spikes that are always there, the spikes that she always has, but she's not having seizures. Okay. But when they totally exhausted her and made her ride a bike for 5 hours, then she finally started to have seizures. So our thing is, if she's not doing stuff, her brain still looks weird on the EEG, but she's not having the seizures, so they can't find the thing. So my thing is like, is she able to like still exercise on the bike to try to trigger the seizure?
Oh, so
if it's inside the spine, you know, because I don't know.
So what we do, we have all sorts of things that we do to induce seizures once we've implanted those electrodes. Because once you implant the electrodes, we don't generally take out the electrodes or do anything further until we've captured at least a few seizures. Now, we do all sorts of different things to get those seizures. One thing we do is, keep people up at night, so sleep deprivation. We have them exercise, so we have like a little, the stairs, the little stairs, so you can do that. There's all sorts of things we do, and so we can capture seizures in a lot of different ways, including like exercise-induced seizures.
Okay, because I was just wondering if it was like, because I was like, is it different than having a regular EEG video or not? But it's pretty much the same. Okay.
Well, no, not.
I meant this brain surgery part's different, but I meant like to be able to trigger the seizure, because we went a long time without them finding. She'd stay 14 days in there, and they're like, and I'm like, well, she's sitting in a bed all day. She's not doing anything. And
sure.
We're like, okay, we finally switched to an epilepsy center where they're like, oh no, we don't let them sit in bed. What are you talking about? They have to, we stress them out until they have one. Right. But I just wanted to know if.
Yeah, we certainly, I mean, my patients, I had a patient I just implanted a week ago and had him walking. He was doing all sorts of, normal things. Actually, one thing go ahead.
I'm sorry.
Sure.
I only have 3 seizures a year. Like I've had 3 seizures since March. I've been a Kaiser member my whole life, so obviously they don't consider that really enough to be a candidate for surgery. But I mean, just having those 3 seizures a year, I mean, they're super traumatic for me,
Sure.
And I don't. What do you consider kind of like uncontrolled seizure? Or like, okay, so they're like, I see people that have 3 seizures a day, so they consider I don't know if you consider that controlled. Would you consider like 3 breakthrough seizures a year?
So we call it, what we look for with epilepsy surgery is medically refractory epilepsy, which means that with the best medications we can give you, that you keep having seizures over that are, that affect your quality of life, affect your day-to-day living, all those things. So if that's something that is affecting your day-to-day life, which it sounds like it is, then certainly epilepsy a surgery is an option. And we actually had, and this is now kind of going away, but we had we were doing all the epilepsy surgeries from Kaiser. Kaiser Sunset was sending all the patients to us. So what they were doing was doing all the pre-op workup, and then they were sending them to us to do the actual surgeries. What I would say, is what I tell all my patients is that you are your best advocate. And so if you think that that's what you want, which I think sounds like a reasonable thing, then what you should do is really start to push for that. Because, even in that setting, if you push for things, they will certainly do them.
Thank you.
Oh, sorry, go ahead.
My question is, what are your various types of surgery? Because I've had brain surgery and I had a piece removed and slits and stuff in that. What other options are there other than removal?
Okay, so that's a great question. So you're talking about not doing brain surgery. You're not talking about taking out pieces of brain. You're talking about what other options are available. So
no, options that are surgical but not removal.
So there are 2 things we can talk about. One is the VNS, and if you had a VNS, we can talk about VNS, and the other thing we can talk about is RNS, or NeuroPace. I don't know if you've heard of that. So VNS is a really good option, especially in the patients we talked about at the beginning who have generalized epilepsy. So patients who their entire brain has seizures at the same time. It's not one area that starts a seizure and the seizure kind of goes everywhere quickly, but the patients who have their whole brain starts and stops seizing at the same time. So VNS it's called a vagus nerve stimulator. So what we do is we make a small incision on the neck. We implant an electrode that goes around the vagus nerve, and then we implant a small generator just by the chest wall. We have, Scott is here. We have the booth here. You can take a look at what the generator looks like. It's pretty small. It's about that big and fairly thin. It just sits under the skin, and essentially what it does is it sends this continuous signal to the vagus nerve. And no one really understands why that does anything, but for whatever reason, it continues to stimulate the vagus nerve, and that gives the brain this kind of this continuous input, electrical input. And for whatever reason, we do see people have decreases in seizures. Now, in terms of what their seizure outcomes are, usually we look at it in the 2-year, 5-year range. And the way we like to say is that there's a third of people who have a significant improvement in their seizures. And I've seen people become seizure-free, but mostly it's a significant improvement. There's a third of people who have a smaller reduction in their seizure burden, and then there's a third of people who have very little improvement in it. Now, we can't tell which patient will fall into which category, but in terms of the surgery itself, it's a fairly low risk, low difficulty procedure, and you go home the same day. And it's and for people who it works in, it works very well. One of the other things that the VNS has is that you get this a magnet which you can swipe to when you feel a seizure coming on. And a lot of people who have seizures, they like that because it gives them this feeling that they have some control over the seizures as it starts to generate. So the VNS is one option for what you're talking about. The NeuroPace or the RNS is another option, and that's more of an intracranial device. And the way that works is that, say we find that the seizures are coming, you have focal seizures and they're coming from your language area, so specifically where you talk. If I take that area out, you won't have seizures, but then you also have a lot of difficulty with speech. So what we do in those cases is what is called RNS, and what that is we put these small electrodes on the brain, and then we implant a battery into the skull actually. So it sits flush with the bone. You don't actually notice it. When you look at it afterwards, you don't see anything there. And what it does is a similar idea. It listens for seizures on the brain, and it works kind of like a pacemaker does in the heart. When it starts to see a seizure generate, it sends an electrical activity to that area and it stops the seizure, or at least that's the goal or the theory behind it. What we found with those patients is that about 50% of those patients will actually have a significant seizure reduction after, about 2 years after surgery. So if we know where the seizures are coming from, like what it sounds like for you, but it's an area that we can't take out, especially people who have, MST, multiple subfield transections, it's a much better option than something like that. And it works really well, and people do very, very well from that surgery.
So even if you had multiple foci.
Yeah. So you can do. So it comes with 3 electrodes, and you can plug 2 of them into the battery. So if we know that, say, both your temporal lobes cause the seizures, or say we find 2 small areas that cause the seizures, we can put 2 separate electrodes on them, attach it to the battery, and it constantly listens for the seizures. So one of the things I'm sorry, there was more questions, I think.
What is your opinion on a hemispherectomy, removing the brain matter versus just doing it the same?
So, okay, it's a very good question, and I actually have written a lot about hemispherectomy. It's one of my favorite procedures. There's 2 thoughts on hemispherectomy. So one thought is, well, first of all, you have to look at the pathology. So there's multiple different, causes of hemispheric epilepsy. So for those of you who don't know, so hemispherectomy is a surgery you have to use when you have an entire hemisphere which is diseased and is causing the epilepsy. One of the things that people have is called a perinatal stroke. So at some point during birth, they have a stroke on one side of their brain, and that causes the whole hemisphere to seize. In people like that, the best option is what's called a functional or disconnective hemispherectomy. And the idea of that is that we leave a lot of the brain tissue, but we separate it from the normal hemisphere, which is the other side. You can do that in something like a perinatal infarct or a stroke, because there's lots of brain that you want to leave as much brain there, because what we've found is when you take out that brain, there's a risk of having hydrocephalus, which means increased fluid on the brain. And so ideally we try and leave as much as we can. Now, on the other hand, in people who have what's called hemimegalencephaly, so what that means is that the brain, one half of the brain grows abnormally. So the entire half has some sort of a dysplasia or abnormal brain tissue. In those patients, we found that if you take the entire hemisphere out, they have a better chance of seizure freedom. And it's really more in terms of the surgical technique, because in the surgeries where we disconnect, what you want to be able to do is say that, in the surgery, I'm looking at it and I can say, yeah, this hemisphere is completely disconnected from the other hemisphere. With hemimegalencephaly, because the anatomy is so abnormal, I don't think that you can do that. And so I think in those patients, you have to do hemispherectomy. Do you have a specific type of, is there something specific you're wondering about? Or?
Yeah, well, my son had a traumatic brain injury, and his entire left hemisphere is enlarged. But he also, he's having seizures, which I'm pretty sure are coming from the left side, but he also has he also has a stroke on the right that also has epileptic waveforms. So I think a hemispherectomy is probably in our near future.
Yeah,
but
I would say so.
Just trying to figure that all out.
Yeah, I will tell you, so we talked about temporal lobectomy, seizure-free outcome 60 to 80%. If you look at the literature for hemispherectomy, it is the best surgery. It's even better than that. It's like in the 80 to 90%. Some people, have even higher rates than that. So it is a very good surgery. I would tell you that if that was something, if it was an option, I would go with that.
Do you we're getting ready to move to Minneapolis. Do you happen to know of, because there's, I don't know.
How old is your son?
He's 2.5.
2.5.
So there's children's Minneapolis, and then there's also, we'll be an hour from the Mayo Clinic, and I'm trying to figure out if we should do it here.
You live there still?
We are moving there in 5 weeks.
Moving there. So I don't know who does epilepsy at the Mayo Clinic. I don't know, but I can tell you that you're close to the Cleveland Clinic, and then if you were going to have it done, if I was going to have it done anywhere, I would probably have that done there.
Okay. Where?
At the Cleveland Clinic.
At the Cleveland. And what's the wait time? Do you know?
So I don't know actually. I trained there, but I don't know specifically.
You weren't trained.
One of the things I did forget. If there's any other questions, before I get to that, I just wanted to go over the risks and benefits, because the last thing I want to talk about before this is over is that, I think in the community there's a big fear about epilepsy surgery, and that's actually it's kind of sad, because it is one of the things that I tell people, they sit down with me and I tell them the risks and benefits, and they say, really, that's it? I thought I was people tell me I'm not going to walk, I'm not going to do this, and it's really not like that. So the risks of epilepsy surgery, the two big ones we talk about, bleeding and infection. I tell people, I quote, infection rates, I give them less than 1%. Bleeding, if you do the electrode implantations, there is a risk of that, probably between 2 to 5% risk of something like that. Those are the big ones. When I talk about, those are the big ones that people complain about. Those are the ones that are actual, real concerning things, bleeding and infection. When we talk about major things like stroke, coma, paralysis, death, I've never had a death, knock on wood. Those kinds of things are very uncommon. People generally, when they have epilepsy surgery, they wake up exactly the way they went to sleep, and that's, I would tell you, that is the bulk of all the epilepsy surgery that we do. In terms of things that people complain about, this is what I like to tell people, because you're going to wake up. This is how I tell people in my clinic. I say, you're going to wake up, you're going to be just like you are now. The things you're going to complain about, these are the actual risks of the surgery. People generally have some jaw pain, because a lot of the surgeries we do, we have to cut into the muscle of the that controls the jaw. So people wake up and they say, I'm having a little bit of jaw pain, I have to open and close my mouth. That goes away within a week. Headache, people have up to about a month or so. Again, that goes away. Things like depression. For whatever reason, some people we see have depression after epilepsy surgery. Again, that's something that's short-lived, and that takes about a month or so. You have a higher risk of developing depression after surgery if you had depression before you had epilepsy surgery. And really, aside from that, I tell you that those are the main ones. It is not something that I have patients who tell they ask me even till when I'm doing the surgery, before that, they'll say, I heard that I'm not going to walk, I'm not going to be able to talk anymore, I have to do this awake. All those things are really, I'm not sure where they all come from, but I think there's a big fear in the community. And I think one of the things we like to do is give these talks is we really like to make people aware of what is out there. Because I think one of the biggest problems is that people just don't know. And I can't tell you how many patients I have who have surgical, surgically amenable epilepsy who, they say, I didn't even know there was a surgery for it, and I wish someone had told me this when I started having seizures 5-10 years ago. And I have patients who come to my clinic after they're seizure free, and they say the same thing, and it's a very it's unfortunate. So again, those are the risks. It's not a risky.
We have a question about the jaw pain. It was 2 months ago today. My daughter had surgery.
Okay.
And she's 61 days seizure free.
Wow, that's fantastic. Wow.
And, she still has jaw pain.
Like right here where they went into their muscle,
Mm-hmm.
it still like hurts to open my jaw.
So what I tell people, the thing I tell people is after surgery, when you watch TV and a commercial comes on, I want you to open and close, practice doing that. And especially if you do it right after surgery for the first 30 days or so, what you really want to avoid is that if you don't do that, what happens is the muscle will scar a little bit and it atrophies a little bit. And when it does, then it's a little harder. But it's a muscle just like any other muscle in your body. If you practice, you open, you work that muscle, it will get better. And so I think it's just something that right now is probably aggravated and irritated and just needs some stretching in it. And ice and heating and all that work for it too.
What's your take on what if your seizures start from multiple areas?
Okay, so it's a great question. So I go back to what we talked about with the RNS. So, well, first of all, I'd say, well, how do you know that they're coming from multiple areas? Have you had invasive studies done?
Yeah.
Okay, so with the RNS system, we are able to cover 2, if not 3, separate areas of where the seizures come from. And then with those patients, what we see is that I had a really interesting patient. He had seizures that came from his left hand motor area. So if you take that out, he's going to have weakness in his hand, and that's something that doesn't really come back. And so he'd had surgery about 15 years ago. They did the grids, they found the seizures were coming from there. Back then they said, we don't have any options for you, so they took out the electrodes and they didn't do anything. So he came back when RNS was available. We did the same surgery, we implanted the electrodes, we made sure that the seizures were coming from the same spot. And then I put the RNS system in there, and he's very, very happy. It's interesting, what he says now is that he said, before he would have this sensation that started, in his right hand and his right leg, and it would start to move upwards. And then he knew that when he had that, then he was going to have a seizure. And so now what he says is that he starts having that feeling, like it starts, like what he normally says, I'm going to have a seizure, and then it just stops kind of on its own. And so, I'm sorry, I don't know if that answers your question.
Oh, yeah, and another question too. Why do you think there's a stigma between CBD?
Okay, so I have a good story about this CBD oil. So they asked me to talk about epilepsy surgery on this PBS show. It was about 6 months ago. And so I went on this show and I was very excited. I was going to talk about epilepsy surgery, and they said, we just want you to talk about treatment of epilepsy. And so I got there, and there was a mother with her child who has epilepsy who's on CBD oil, and then there was a neurologist who also specializes in CBD. And so when I was looking around, I said, I'm not sure if they really care about epilepsy surgery. They want to talk about CBD oil. And so when I was on, we were on this panel, and they asked me, they say, well, what do you think about CBD oil? And so I said, well, I don't really handle the medical part, the medicines part of it. I usually leave that to the neurologist. But, in my opinion, if it works, use it. I don't know why you wouldn't. If it works, then that's a good thing.
Yeah,
if it doesn't,
I live in Minnesota. I'm on. I've been seizure free since about 4 months now.
Yeah. So I mean, I think, like what Dr. Lerner had said before, I think there's eventually we're going to come up with recommendations that say if you have this kind of seizures or this kind of epilepsy, then it's a good option, and otherwise. But again, I will tell you that I go back to what I originally said, which is that if you fail 2 to 3 medications, the likelihood of becoming seizure-free on medication alone is very, very low. And so at that point you want to be evaluated at a real epilepsy center where they're going to talk to you about surgery and other things. So that's really what I tell you. I kind of want that to be the main point of this.
If you have an HMO like Kaiser, let's say, what is can you push to be referred to an epilepsy center?
Yeah, absolutely. So I'll tell you, I'll give you another good story. So I had a patient who was at Kaiser, who's I think 14 or 16 years old, originally he wanted to have surgery done at one of our other epilepsy centers. They were referring out to another epilepsy center. For whatever reason, I think they met with that surgeon and they didn't like him, and so they were going to send that patient to the Cleveland Clinic. And the mother was very, very, she kind of pushed for it, and Kaiser said, okay, we'll send you to the Cleveland Clinic. And then her neurologist said, well, actually Dr. Vadera trained at the Cleveland Clinic and he does the same surgery that they do and you get the same care. So then she came down and they saw me and they actually agreed to it, and actually I ended up doing the surgery for him, and he was seizure-free post-op. So, they will do a lot of the things if you push for it. I think the big thing is that you kind of have to be the prevailing force.
Make noise.
Yeah, you have to make noise. But and I'll tell you, that's what this mother did, and she basically they were going to send her to the Cleveland Clinic, and then she ended up coming to UCI. So.
Thank you so much.
Why are there so many doctors that don't know about the different devices that can be used for epilepsy? And
you mean devices like the surgical devices, or?
Well, both surgical devices as well as the surgery. Some of them have heard about surgery out here, but they haven't really done any study about it. And
so what I tell you, it's kind of what
for me, the way I found out about my surgery that I had was because there was an intern from a college in the doctor's office at that time, and she told me, and I told the doctor.
Well, so I think part of what we're trying to do with all these talks and things is kind of raise awareness, and that's, I think, part of it. Another part of it is that if epilepsy is it's a very difficult disease to treat, and I think about the way I think about it is if I had something like epilepsy or a brain tumor or something like that, I don't know if I'd want to necessarily be treated in a community setting, because I'd rather be in a place where they do a lot of those evaluations, and so by doing those, they can actually then decide what is the best thing, because they know they have available all the various options.
But still, if your doctor doesn't know about it, they can't even suggest it.
So then, like I said, you have to be your own advocate. So people have to they have to look for these centers, go to the centers, say this is what I want, and that's.
And if it's too far away.
Then you got to drive.
Then you got to drive. I'll give you one last thing before I go. So I was talking to a anesthesiologist, and he was telling me, I was talking to an epileptologist, and he was telling me that he tells his patients, when he was in training, he was in New Orleans, and he needed some small sinus surgery, and he looked and he said, who's the best person to do the surgery? And he found someone in Houston, so it's 4, 5, 6 hours away. So he said he drove over to Houston to have this surgery done. And he said that's just sinus surgery. Imagine someone's going to go in your brain and do a major surgery. You want to have someone who knows what they're doing. You don't want to go do it at a community hospital. Okay? Thanks a lot.
Our next speaker really needs no introduction. He's Dr. Raman Sankar of UCLA, very well-known epileptologist, and this talk is called Ask Sankar, and that is because Dr. Sankar is generally challenged with the questions that many doctors, like your last question, this is the type of doctor you go to ask those questions. Why is my doctor not? Thank you, Dr. Sankar.
Thank you. Thank you all for coming. So I'm actually going to start with that last question that you all asked Dr. Vadera. It's a very good question. This is a situation that's getting a little better thanks to social media and other avenues. But the important thing to remember is whether it is epilepsy or other difficult and challenging conditions, it's very important for people in the periphery who treat these and for patients to learn that if you are not managed with a simple approach, you deserve a referral to a good comprehensive epilepsy center. There are a couple of pathways. People these days are finding out a lot from social media. I myself am not very savvy, but my staff are. But if you do social media, you should still eventually wind up at the
a reliable third-party solution to guide you. What I'm saying is, it's very cheap now. Anybody can set up a website, and anybody can say how cutting edge they are. And sometimes even big centers do that. I remember a mom telling me, they saw this on the Mayo Clinic website, they're doing this really cutting edge thing. I told them, actually, everybody's doing it, you know. People just put up, we have a 3T MRI, so does everyone else. Secondly, having those things doesn't mean they're good at using them or interpreting them. So a good way is to start with, for any disorder, if this could be Parkinson's, it doesn't matter. I think a reliable source for you is the Epilepsy Foundation and or meetings like this, where you have an opportunity to actually see everybody, or like the EF, they're kind of aware of who's who, right? That's really a very good place. There are places like epilepsy.com for yourself, because as Dr. Vadera was saying, in the adult experience, every study I have seen for the last 25 years, and it hasn't changed. What's the average delay before an adult person gets epilepsy surgery? It's typically 20 years. That is just incredibly slow. Okay? And the other thing I would say is there are complicated interpretations of certain data. I want to say this because not everybody is a candidate for surgery. But there are many non-surgical options, including medications. Okay? Now, one of the things you commonly hear, and I think it's a little overstated, and I will try to explain this to you in terms perhaps you can understand. It has become very fashionable for the last 15 years for everybody to quote a study by actually a very good friend of mine, right? This is Dr. Martin Brody from Glasgow. He's a good friend. I've been to his house. He's been to my house. We drink scotch together. Very nice man. And he published an important paper, but it has become a little over-interpreted. And that is, I don't want everybody here to think if you've failed 2 or 3 medications, you're doomed. Right? That's the message of Dr. Brody's paper, but it is incorrect. I want to make sure I say that because I think everybody needs to get a proper referral and evaluation. But it doesn't mean like if you're not a surgical candidate, you're screwed because you've been on 3 drugs, right? Because if that was really true, right, no drug company would go into the business of making drugs. Correct? It really cannot possibly be true. It is an artifact of a funny situation. Let me explain this. You'll find it fascinating when you think this through. The thing is, we find that different people respond to different drugs. You take any good drug, you saw the booth from Cure, right? Good example. Cure was founded by Susan Axelrod. Again, a very dear friend of mine. She's the wife of David Axelrod, who ran Obama's campaign, right? Susan and I were recently at a meeting in Brussels just a few weeks ago. And the important thing is she'll tell you how much her daughter suffered. In fact, they'd gone through every drug in the book, and there were more than 3, until Keppra came along and then she became seizure-free. That's just one tip of the iceberg, right? But why is it that we keep saying none of our drugs work for all the patients, so we must be failures? Well, you know, I like to think we're not. Actually, I'm a pharmacologist. I'm a medicinal chemist originally at a PhD level. I think we're doing a pretty good job compared to most disorders, because if you look at diabetes, hypertension, they also have a lot of drugs and some people are hard to treat. But the important thing to appreciate is epilepsy is not one disease. You understand? So it's not one disease. None of the drugs work for everybody because we don't do trials based on what the patient really has. We just say the entry criteria is an observation period of 4 to 8 weeks, during which if you have 3 partial seizures, you're ready. But the truth is, as Dr. Vadera, who's still here, will tell you, any decent neurologist and radiologist can look at your MRI and say, this looks like hippocampal sclerosis, a common cause, or cortical dysplasia, or post-traumatic, and they all have different features to them. But you see, we lump them all in the same drug trial. So let me get a little more granular. You all heard, the women's side of the equation here knows all about breast cancer, right? There's a magic bullet called Herceptin. You heard of that? Herceptin is like magic if you have a mutation in a gene called BRCA1. And if you give the same medicine to all breast cancer patients, you won't have a hit rate of 95%. It'll drop down to maybe half or 2/3. Right? If you give it also to lung cancer, intestinal cancer, it'll go further down. And this is the problem with epilepsy. We have a few drugs, we just throw it at everybody. And you cannot expect any of them will work. It doesn't mean it's not a good drug. It's just that it has not been a good match. And sometime in the future, perhaps, we will get better at, sorting patients. Right now, our knowledge is beginning to improve with genetic studies. But it is still not as simple, because unlike some forms of cancer, where they have a very key signaling pathway or a gene, almost no epilepsy is what we call monogenic, right? There is like a large number of genes that kind of up the ante are somewhat protected. So you could have two people who are in a car accident, similar injury, 1 month stay in the ICU, but one gets epilepsy and the other doesn't. But you have always known that, right? Winston Churchill was a fat man who smoked a cigar all his life and lived very long than my skinny dad who was a vegetarian and non-smoker. Because there are many, many, many factors. And that's why we never really know who's going to benefit from what medication. And there are different combinations possible. I just say this so you have a little better feel for what we mean when we say, yes, your chances are down. Most straightforward cases respond within the first couple of drugs that are well chosen. But people also fail drugs for other reasons. They control your seizures, but you can't talk. But they control your seizures, and your pancreatic enzymes went sky high, and you're in the emergency department. You need to move on, right? So there's a lot of reason why they're not a perfect match. But I think the biggest thing is to understand that epilepsy is a different disease in different people. And I treat predominantly children and some young adults and many adolescents. And there is still a lot of art and a gut instinct. So my suggestion to you is, if you're in a situation where you've not done well, you should get referred to a comprehensive epilepsy center, because if you are a surgical case, that comes closest to a cure. But even if you aren't, almost anybody, I tell them, I promise you, I'll change your outlook. Because there are so many tricks, right? We have dietary therapy, we have neurostimulation, that comes in different flavors. I heard you talking about RNS when I walked in, right? And there's a new twist on the VNS that is kind of quasi-RNS. There's a lot of options, but even, what combination of medications remains, how insightful is a doctor. Some people are better at it because that's all they do, right? I am a neurologist, but I can tell you I don't really see patients with MS or Alzheimer's or Parkinson's, or I don't even see people whose primary thing is ADD. In pediatrics, I do epilepsy. So I think the important thing is to find the right place. Your foundation is a good source, epilepsy.com, any kind of a service organization like that. That's a good place to start. And then, you'll obviously connect with people. There are very specialized things. For children, there's a hemispherectomy foundation. And if you look at the board of directors and the scientific advisory board, it's a lot of people from Hopkins here, Cleveland, right? Good people, and you're going to get good advice. And so that is also kind of a summary about how I view treatment of different types, what works for who. It's a complicated process. And it also depends on something we're increasingly aware of, that is, to treat epilepsy, we have to treat epilepsy and the comorbidities, right? There is an increased proportion of people in epilepsy who have depression, children have learning disabilities, and it's really takes a sophisticated approach, because sometimes an attention disorder or impulsivity from, let's say, phenobarbital may not look different from just innate ADD, right? So you really have to say, what's the drug effect, what's from the seizure, what's the underlying fundamental psychiatric problem, how are they interacting together, and these are all why you go to highly specialized centers, right? But
are you aware of, I've been looking at some studies that say that, for example, trileptal can actually, for children with absent seizures, make it worse.
yeah, it's actually extremely well known. It's not relatively...
Because his doctor has him on this because his seizures were more convulsive at first. Now the absent seizures are increasing. He's got an appointment soon. Telling her all of that, she should be able to move him to something else. But I guess
well, the first thing is we have to sort out whether the child actually has absence or something else, right? Because we want to think that an absence is a staring spell, right? But what we clinically call absence, the classic childhood or juvenile absence epilepsy, has some important EEG findings and clinical findings. The spells are usually shorter than those who have, let's say, complex partial seizures that start with staring and may go on to a convulsive phase. But the EEG signature is very, very good. You can see whether it has a focal onset. But if it is true absence, what we call classic generalized spike wave, you know, which is often brought about by hyperventilation during the EEG or even in the doctor's office, for that, yes, Tegretol is the wrong drug. So when they say if you fail the first 3 drugs, if they went to Tegretol and Trileptal, you're blown through 2 drugs that are totally inappropriate. Yeah, right? And you can go to Aptium and you can run through 3 drugs that are more or less the same and wrong for the disorder.